Right. So we heard GLP-1s as weight loss. Like that's what it's known for. But does it have anti-inflammation? So when your body swells, what really happens? GLP-1s can help with inflammation. How does it work? And I think that if you are a patient, you're listening to you right now, and they have these other issues and things like that, that they are considering GLP-1s, what actions should they take to move forward? Like, hey, I want to do this. What do you recommend?
Always about finding that balance about what are the potential benefits of being on the medication and what are the potential risks, and where does that balance lie? Are you going to have more benefits than risks?
What is inflammation from a medical perspective, and why is that a problem? So can it help with inflammation?
With a little health and a little wealth and a lot of love, that's a life that we live. Seuss and Scrubs.
Hello, everybody. Welcome to another episode of Seuss and Scrubs. We talk about a little bit of health.
A little bit of wealth.
And a lot of love. All right, guys, we have a good one for you today. You heard about these GLP-1s.
There you go.
I always mess that up. I always go GPL-1s like I'm dyslexic, but GLP-1s. You heard about it for weight loss, but have you ever heard about it for inflammation? So what Emily's going to do is we're going to walk through some research backed by evidence-based. We're an evidence-based podcast and talk about some pitfalls. We're really going to explore this topic. So can it help with inflammation?
I don't know. I guess you'll have to stay tuned.
Yeah, absolutely. All right, guys. So join with me is Emily, MD. She's double board certified, and she's our gut hormone and weight loss doctor. Fun fact about Emily. If you guys have been to our website is live. By the time we record this, it actually went live. It's going live tomorrow. We're in May, but you probably won't see this episode until a few weeks. She wore this dress on our photo shoot. It's a 1920. I think she looks great. So, to you.
Well, this is my very handsome co-host and husband, Mr. Zachary SVP, who will help you retire early. And fun fact about him is that it is his birthday tomorrow.
Oh, geez, it is.
Happy early birthday, honey.
Are you going to sing me a song?
Maybe later. It's not midnight yet. But later. A little happy birthday, Mr. President.
All right. Okay, so we're going to skip over the 30-day challenge, which we're focusing on our budget. We're actually doing a very good job of managing our budget. So Emily's been taking over our budget and just walking through all of our financials. So we're going to skip over that for now because there's really no change from last time we recorded. Okay, time for our first segment, which is Refactions. Refactions! Do we want to give some information about this refaction in particular? We're big fans of Mark Hyman, functional medicine specialist. Do you want to go ahead and gush over him before we jump in?
I do. I am a big fan of Mark Hyman. And this episode, he has a couple guests, Tina Moore. There's a very heated discussion. I think anytime you talk about the GLP-1 agonists, Ozempic, Wegovy, people have a strong opinion about it. They have something to say. And I loved this episode because you hear from different perspectives, completely different point of views, and people who are vehemently for or against the medication. I just think it was an interesting listen. I think the episode was probably 2 hours long, but I enjoyed listening to the whole thing. Yeah,
and I think what we do is, guys, we do about 4 to 20 hours of research per episode, and we don't just pull random articles. First of all, we're experts in our field, but then we look at everything that's evidence-based, whether it's in health or wealth. And so Emily definitely took that opportunity to do that. So I'm going to play this clip. I'm going to play the first 24 seconds, and Emily is going to react to it. So here we go.
These peptides have been shown to heal heart tissue and to reverse heart failure. So I've got one patient on it for high blood pressure. Tiny little dose, high blood pressure's down. I personally take it because I have psoriatic arthritis and I have crippling pain from tip to toe. It doesn't matter how clean of a life I live. It doesn't matter how clean my fish tank is. Menopause hit me. So tiny little doses mitigates my autoimmune conditions like nothing I've ever used.
All right, welcome Tina and welcome Callie. It's great to have you both on the show.
Yeah, so in this episode, basically he has two opposing viewpoints. He has one person who is completely against the use of these GLP-1 agonists because he sees it as a crutch. He sees it as something where you're just using this medication. You're not implementing any type of lifestyle measures. And it's basically getting the entire American population on this medication, and they're going to have to be on it forever. And it causes all of these dangerous side effects. And then you have this other point of view where someone is using it at low doses, but using it to try to help improve metabolic health, but also some of these inflammatory conditions, and is seeing a lot of benefits in the patients that she's using them on. And so we'll kind of, I know there's controversy. She's a naturopath. She uses it at kind of sub-treatment, subclinical doses below what we see in the FDA-approved brand name medications. And so she's getting her medications obviously through compounding pharmacies because she's able to titrate the doses herself. There's a lot of controversy around that. But I think it's important to maybe talk a little bit more about what research we actually have with using these medications for inflammation alone and not just for weight loss or diabetes.
Yeah. There's a few things you said that actually I just wanted to stop and just bring the audience along with us. So, and guys, I'm not an expert by any means. This is why we do it. I'm not an expert in her field. She's not an expert in my field. So we glaze over a topic you just don't know. We pause and rewind. So we're going to pause and rewind. So one thing is we did a whole episode on compound pharmacies and GLP-1s. And so that's probably our second hottest episode out. It's been trending for a while. So if you haven't caught that, let us know. I'd love for you guys to check that out. I was really against anything like that until I really got into the details and based on evidence that you provided. So definitely check that episode out. Also, if you've been living underneath a rock, GLP-1s, we know what GLP-1s are at this point. So if you do not know what that is, there's another episode, our highest trending episode for Ozempic face. And so we dive deeper into what that is. So cool. Okay. Anything else you want to say about that one before we move on to our next segment?
Nope.
Okay. So our next segment is Bum Fuzzle Battle. Bum Fuzzle Battle!
So Bum Fuzzle Battle is basically a segment where we will tell you, or I will give a word that is a health term, and my co-host, who has probably no idea what it is going to try to guess what exactly that word means. And so the word for today is cytokines.
What? Cytokines. Okay, I see it on the screen here. If you guys see me looking up, I'm looking at the screen. While I'm thinking, I do my best thinking out loud. So me and Emily, we try to incorporate who we are into the show. We're big fans of Family Game Night. So these Bum Fuzzle Battle, Refactions, these 30-day challenges, it's really just who we are as people outside of the show. So Cytokines, I bought myself enough time.
I feel like you're stalling over there.
I don't know what cyto means, but Cytokines, any doctors listening, like, that's what it is. That's what it is. It is, I don't even know where to go with this. A cell within the mitochondria that produces some power and helps the mitochondria go.
you used a lot of words there. That was a good try.
That was not a good try.
I mean, the fact that you said mitochondria is
powerhouse of the cell.
There you go.
Are you getting turned on?
You take that from biology class.
Yeah, I actually like biology class.
So cytokines are basically proteins or signaling molecules that help to attract certain cells. They can be either inflammatory or anti-inflammatory. So they help basically with signaling in your immune system to get the right cells to certain places. And they can enact activities on the actual cell that releases them, or can act on other cells, other surrounding cells. Kind of think about it as like if you're cooking like chocolate chip cookies, and that smell starts to waft into the other room, and you smell the chocolate chip cookies and you love the chocolate chip cookies. And so you decide to come into the kitchen because of that scent. And that's the way I like to think about it, how you attract other cells to a certain location to do their job.
So I'm assuming the reason why you chose that word for today is because, or is that explained later?
Well, we were talking about inflammation today. I think the secret's out.
Well, that's a good segue. So can you explain what is inflammation from a medical perspective and why is that a problem?
So inflammation it's supposed to be a protective mechanism. It's supposed to be something that benefits you. So if there's damage in some part of the body, whether it's injuring a part of your musculoskeletal system, if it's damage to a vessel, you want your immune system to come and fix it. You want them to help to, if it's an issue with bleeding, you want the immune cells, you want the different types of cells to stop the bleeding and then repair. And so if it's acute inflammation, it's a good thing that you have those cells that come to repair the damage. But if it's something that's chronic, that's continuously happening, that never gets better, the insult never goes away, then that's where things become problematic, and it can lead to chronic disease, can lead to permanent damage.
So when things are inflamed, like I think of inflammation and things swelling. So when your body swells, what really happens?
So it's basically your body trying to get your immune system to that certain site.
Got it. Okay.
So
And what does it bring, like white blood cells and just like to fix it and repair it or whatever?
yeah, but it brings white blood cells, things called fibroblasts. It brings different types of cells that have building blocks basically that can rebuild and that can make things new again.
Gotcha. Okay, so repair. So inflammation is just pretty much your body signaling and then drawing it to that problem. I guess the cookie example. So is it the cytokines that does that?
They can. There are a lot of different mechanisms, but the cytokines are those like chemical signaling molecules or proteins that can help that process, help attract cells to certain areas.
All right. So we heard GLP-1s as weight loss. Like that's what it's known for. But does it have anti-inflammation properties?
That's the going thought. The theory is that there are a lot of mechanisms that can cause this anti-inflammatory effect, and so there's the kind of an indirect mechanism. So by helping to decrease weight, so by helping people lose weight, you are helping inflammation in that way. And so we know that fat cells produce chemicals, inflammatory chemicals and cytokines that are pro-inflammatory, that promote inflammation. And so if you're on a medication that decreases fat, and it's especially what we call visceral fat, so it's the fat that surrounds the organs.
Yeah. And that's the dangerous fat, isn't it?
Yep, that's the fat that's supposed to be or considered to be the most inflammatory, that's considered to have the highest ties to things like cardiovascular disease. And so in that way, if you're decreasing fat, then you're decreasing that inflammation. Or for people, say, who have all of that pressure on the joints, if you're a certain number of pounds, it's going to put more pressure on your knees, other joints, and so that causes inflammation in the joints. And so if you're losing weight in that way, it can help with the inflammation. And then also things like sleep apnea. You've got so much weight on you that it's kind of cutting off your airway when you're sleeping at night. And so...
And may I pause you there? So there's this huge debate online where, I'm a big fan of the body positivity movement. I don't think anyone should make fun of anyone, of anything. I just don't. We all do it. We all judge people, right? However, I think people really don't take this seriously if you have excessive weight on you and how serious that issue is when you sleep. So, and I've said this before, and I always will say it in every episode. My mom's best friend took us in when we were homeless, and we lived with her. Her name is Janice, and she was 40 years old, and she was 5'3", about 400 pounds or so. And it doesn't, I'm telling her weight just to kind of picture that. And she passed away. She died in her sleep alone. And that, it breaks my heart because she was like my second mom. She really, really was. I mean, and so that's just something to think about when I don't want people glaze over that. That is a serious issue, and it does happen. And I've lived it. I've been around that. So anyway, you said that. I just want to just jump on that because I just saw something online recently about, if people in the body positivity movement weren't taking that seriously. It is a serious thing. Sorry.
Yeah, and it's not just the fact that sleep apnea makes you snore. I think a lot of people kind of have that misconception that it's just a snoring issue, when in reality you stop breathing for a certain number of seconds, and a lot of times it's repetitive throughout the night, and that lack of oxygen puts strain on your body, and that can promote inflammation as well. And so a lot of people that have persistent sleep apnea can have blood pressure issues. They can have high blood pressure. It's putting strain on the heart. It's not something that should go unchecked, and it's something that GLP-1 agonists with weight loss can help to correct or at least significantly improve.
So, okay. So it can help with GLP-1s, what you're pretty much saying, or GLP-1s can help with inflammation. How does it work?
Yeah, and those are more of the indirect ways, and then also correcting blood sugar, helping with diabetes control.
Wow.
So I think there are several different mechanisms that can be helpful. It's the weight loss, but it's also the direct effect on the pancreas, on blood sugar. It helps to regulate blood sugar and insulin. And so you're seeing a decrease in your blood glucose. And we know that persistently elevated blood sugar has end organ effects. It has issues, negative impacts on your blood vessels, on your kidneys, your eyes, on your nerves. So there are a lot of different things that can be affected if the blood sugar is high. And so just by improving your glucose control, that can help with inflammation. And so those are all of these kind of indirect ways that it can help. And I think we all, as in the medical, all physicians knew that was the mechanism, that we understood why that improved inflammation. But I think this other theory, or another way that it helps with inflammation, is that there are actually GLP-1 receptors on immune cells. So on white blood cells, kind of our infection fighting cells, there are actually receptors where this hormone or this molecule acts to help with our immunity.
Gotcha. And just for those who don't know, but your body naturally produces GLP-1s, right?
Correct.
Right.
Yes.
And that's something I don't think that's widespread knowledge. At least I didn't know, guys. So interesting. So tell me more about the anti-inflammatory, about GLP-1s, and the research that you've done, and how those trials have been in humans. And I will tell a story. So I had a friend of mine who is type 1 diabetic, and his father had a heart attack. He's doing well, and they put him on GLP-1s, and more, yes, to regulate weight, but to manage his for his heart, they said. And I did not know GLP-1s had a direct benefit to help with your heart. And I might be butchering that, but that's what I understand. And I think that's kind of like what the theme of this episode is.
Yeah, and it's a newer FDA criteria. So there are certain criteria that the FDA puts out on why someone should be using these medications. And so the first one that was approved was for treatment of type 2 diabetes. And then from there, it was approved for weight loss, weight management. Mm-hmm. And then there is also an indication for cardiac risk reduction.
Right.
And there are still some numbers that come into play when you talk about certain BMIs, body mass index numbers that are cut off. So typically, if you are obese, if you have a BMI over 30 or 30 or above, then you're a candidate for using it for weight loss. If you have a lower BMI than that, but if it's 27 or above and you have other issues, you have cardiovascular disease, prior stroke, high blood pressure, high cholesterol, that's another indication to be on the medication. And then diabetes, no matter what weight you are, if you have diabetes, you are a candidate for the medication.
Yeah. So there's a lot more than just weight loss, is what you're saying, and a lot more benefits. Right now we are focused on inflammation, and so I think that's a direct correlation of what this medicine can do. So okay. So anything else on the research that you want to say, like in humans?
Yeah, we haven't even started talking about research yet.
But let's pause. That's why we're having this episode, guys. We're not just giving you information here. You get so much information. You don't know where to go to. You don't know who to trust, right? This magnificent woman here does this day in and day out, every single day. She has patients in her practice, in her clinic. She lives, breathes, sleeps this every single day. And we're trying to get the best information out there because we will take a stand. We'll take a stand at the end and go on research.
Yeah, so there's a lot out there. There's a lot to sift through. And there are kind of different studies that you can consider. So there are in vitro studies, which are basically studies in a lab of the cells, but not necessarily in the body, whether it's
Like babies, I thought.
Yeah, and it just means kind of like not in a test tube, but it's not within, they're just studying it outside to see the effects of certain cells and how they interact with certain things. But there are in vivo studies, and that's in live animals, whether it's mice or humans. And there are those two type of studies too. There are studies where they specifically study in rats or mice, and then they do more clinical or human studies. And so it's important to know the difference between the three of those, and to know if you're seeing positive effects, can you actually correlate it if they're doing an in vitro study to the general human population. Right. So you have to be cautious, and you can't be overly excited about certain things that they find in vitro studies or even in mice studies until...
And you're a cautious ass person. I'm going to say it again. She is a cautious ass person. Before we started filming today, we got in a little argument because one word was misspelled. And by the way, we have about 400 posts between my account, her account, and Suits Scrub. There are going to be misspellings. This woman pays special attention to detail. That's why we did this podcast, because this is exactly in her lane. And go.
It's one of my pet peeves. I feel like I'm a little bit of a grammar police.
Well, you're OCD too.
Yes, with the there, to the two, using the right yours. And twos.
Listen, in that example, I agree. But go ahead. We digress.
So different studies, and there's a wealth of knowledge out there on the anti-inflammatory benefits of GLP-1s, and I think you have to kind of take it with a grain of salt. But there are different studies. So there are studies on how it can potentially decrease inflammation in the lungs. And so there were studies on potentially decreasing inflammation in asthma and COPD. I believe those were more mice studies. They did studies. I feel like we were just kind of trying everything during the midst of the COVID pandemic. But when more of the severe COVID-19 infections were a real issue, probably in 2020, 2021, they did show that giving diabetic patients GLP-1s while they were actually acutely ill with COVID in the hospital tended to decrease the negative inflammatory effects in the lungs. So there's something called ARDS that's basically really severe inflammation in the lungs that you can see often with things like COVID and flu, and decrease the negative endpoints like mortality and lung inflammation. And that wasn't a very high-powered study, and it was, I think, only used in diabetic patients, but it shows the potential benefits outside of just blood glucose control. And we know that COVID-19, especially some of the earlier strains, were very pro-inflammatory. And then also we know that things like neuroinflammation, things like Parkinson's disease, Alzheimer's, ALS, there were several in vitro and mice studies that showed promising effects of GLP-1s on these neurodegenerative disorders that we don't really have a lot of great treatment for. In certain areas we do, but in Alzheimer's, we don't have a lot of treatment in ALS. And so I think those are promising. I think there are a lot of research studies, maybe more clinical studies that are going on now that will research that. But I would say specifically with Parkinson's, they did do a clinical study in humans to show people with Parkinson's disease on a GLP-1 agonist for a year tended to show improvement in their functional score versus the control group, which didn't have GLP-1s. They had a decline. So it's not, just that they both stayed the same. One actually improved and one got worse. And so I think that's something to keep in mind, that there are a lot of potential benefits. We've already kind of talked about the cardiovascular benefits. And so we already use them a lot in patients who have cardiovascular disease. But it's not thought to be just the improvement in blood sugar and the improvement in insulin, but really this anti-inflammatory effect.
Have we always known this, though, as far as with GLP-1s? And what would you categorize GLP-1s? This is kind of off the script. This is more for my edification. So is it a peptide? Is it, what exactly is a GLP-1? Is hormone?
Yeah, I guess I would consider it a peptide. And
what is a peptide?
It's basically a grouping of proteins.
Got it.
And hormones, you can kind of use that term, I guess, kind of loosely as considering it's more of a signaling molecule. So I would kind of consider it as a hormone as well.
So it's like a hormone and a peptide?
Yeah. And,
wow.
And it can, so basically it's released from certain areas and it can go and move all over the body and work on different receptors. And there are GLP-1 receptors in all kinds of different areas. So we know more by using them as these weight management medications. We know that they can affect the stomach by slowing your stomach emptying after you eat food. And we know that it can work on the pancreas to help with insulin and blood sugar. And we know that it can impact the hippocampus, that kind of the drive to eat, the hunger, the appetite.
The food noise, right?
We know that there were receptors there all along, but I think now we're finding that there are receptors in the immune system. We know there are receptors in not just the hippocampus of the brain, but kind of all over the brain and the cortex of the brain. So basically kind of like the main part of the brain. And
this
so
is just recently, right?
Relatively recent. I think these medications have been around for a long time, like exenatide. So there were brand names called Byetta and Victoza that have been out much longer than just the Ozempic and the Mounjaro, which has got a lot more of the press. People know more about those medications, but these GLP-1s have been around for years. And so I think they've been seeing some of these effects, but they're not really mainstream knowledge.
Gotcha. So we talk about, well, I'll say this. I was today years old, understanding that GLP-1s can be used for inflammation purposes or inflammatory purposes. So if this is the first time you have heard this is the first time I've heard this, drop us a comment. Let us know what country you're from. I'm very interested in this because, by the way, we covered GLP-1s and weight loss. It's probably our most trending topic, and we keep doing it because this is what you guys want to learn about, right? So just let us know in the comments. We talk about the benefits, right? We are a 360-degree kind of people. So let's talk about some of the challenges or some of the pitfalls using these for inflammatory purposes.
So we already know these great benefits of weight loss and improvement in metabolic syndrome. And that's why everybody's clamoring to get these medications,
Right.
because
100%.
it's really one of the first medications that we've seen such great success that you can potentially use long-term. And I think we're already seeing all of these shortages, especially with the brand name medications. They can't keep up with the demand as it is. So what happens?
And for the right reason, because they actually work.
Yeah. And so what happens when there are more indications that we're treating them with? And how expensive are these medications? I think it's so interesting. They talked about this in the podcast, and then I've seen some people post it on different obesity medicine forums, but talking about how much Novo Nordisk charges a Americans for the medication versus people in other countries.
So there's a discrimination and is it how much?
Well, there's this concern that...
And Novo Nordisk, by the way, is owned by Ozempic.
Yep, so they're the ones that Ozempic and Wegovy, semaglutide.
Some rich people.
So I believe they charge European countries maybe $100, $200 per month per patient, whereas the cost in America is anywhere between $1,000, $1,500 a month for these medications.
It's the same, isn't it?
And so basically kind of
Why is that?
exploiting Americans, because I mean we have a major obesity issue, but I think
But a lot of other countries are fast following on because our
yes,
westernization and our
spreading.
the food, the fast, cheap food, delicious food is spreading more and more and more. So we're seeing this not only from an American perspective, and they say England's right behind us.
yeah, and I mean we did a prior episode on
We
the
did.
blue zones, but talking about how those blue zones are shrinking smaller and smaller
Yeah.
because there are fast food restaurants just creeping into all of those areas, and it's a shame. It really is.
Yeah, it really is a shame for sure. Okay. So we talked about side effects. We talked about the pitfalls. We didn't really talk about the side effects. Like we talked about this before. I'm assuming it's the same thing.
Yeah, so I think the cost is a big issue. The availability is an
Right.
issue.
The side effects.
The side effects are, I would say, something that you should consider, and you should know it's not something to be taken lightly. There are some people that have minimal side effects. Everybody is impacted differently.
Right.
There are some people that have more severe side effects, and you also have to consider how severe things like their type 2 diabetes or their other conditions are, because you want to make sure that people are getting appropriate nutrition, and the side effects typically are more GI related. So
Right.
nausea, vomiting, abdominal pain, constipation, diarrhea, I would say are the most common. And so if you are one of those people that has severe side effects and you're not nourishing yourself, that can cause other downstream
Right.
issues. And then we talked about this in prior episodes, but the more concerning side effects that we hear about, like gastroparesis, which is basically kind of like stomach paralysis, it's something that we typically see more in people who have diabetes. And if you have already end-stage or poorly controlled diabetes and you put a medication on top of that slows your stomach emptying, then that could be a recipe for disaster.
Mm-hmm.
And then bowel obstruction is another more severe side effect that can
Right.
be very dangerous.
What you hear all in the news. And, let's just dig into this. We are not betraying our brand. I know you guys are probably listening to us and thinking about who we are. We do believe food is medicine. And one thing you said is everyone is different. And what I know, and guys, I went to a functional medicine conference, this is why I can kind of talk about this, is functional medicine is so interesting. And Emily's not all the way functional and all the way traditional. She's right in the middle, which I think is the sexy part to be in, to be honest. And she's probably more on the functional medicine side, treating the specific problem. But what's interesting about functional medicine is you look at someone uniquely themselves and you treat how they are bio makeup. I'm probably mucking this up. And you find a specific plan based upon that individual person. That's what makes functional medicine so sexy, because yes, there are studies that say this, there's studies that say this, but you could be here, you could be here. And it's hard to navigate that. So you have to really make sure you understand your full profile before you take on anything. And guys, in investing, it's the same damn thing. If someone asks me, what's your investment advice? I tell them, listen, what do you do? What kind of person are you? I do real estate. That doesn't work for everybody else. It doesn't work. If you're in Charlotte, North Carolina, it works. Not at 7% interest rate. But if I'm like in damn California, I'm not going to tell you invest in real estate. It's the same damn thing if you really think about it. You got to understand your profile, what your competitive advantage, and what uniquely is yourself. So I just want to go on a little tangent there, because I think it is important to let our viewers or listeners know that we're not betraying our brand. We believe food is medicine. We're big naturalists here. However, there are some benefits that we're uncovering as it relates to this.
Yeah, and I think that's a good point. It's always about finding that balance about what are the potential benefits of being on the medication and what are the potential risks, and where does that balance lie? Are you going to have more benefits than risks? And I think that's what the FDA tries to do by giving those cutoffs, the BMI cutoffs, because they want to say, are these people truly going to have the benefits, the metabolic benefits, and is it worth the risk of some of these GI side effects? And I think there's a safe way to do it. I think there's a safe way to manage and make sure that those GI side effects are minimal and that people tolerate the medication. But I don't think it should be just something that you write a prescription for and you don't caution the patient on what to look out for and how to take the medication.
And which you're very cautious on that.
Yeah, I think it can be abused in a lot of situations, because anytime you connect a medication to weight loss, there's always the potential for misuse and using it for
vanity,
for the wrong reasons. Or there are a lot of people out there that have eating disorders and disordered thinking surrounding their weight, and so you really have to be cautious with who is truly going to benefit and who it could be detrimental for.
I agree with you. And so that's a good segue into the next question. So take us on a journey. We talked about your evidence-based research, which you always do before every episode to make sure you're putting out quality information. Have you had anyone in your direct practice that you've seen benefits up and beyond weight loss? We're talking about inflammation, so maybe tie it to that.
Yeah, I mean, I prescribe this medication a lot. I'm an obesity medicine specialist. It's kind of my bread and butter. So I see a lot of,
no pun intended,
a lot of people on this medication, and I see the side effects and the benefits. And I will say something that maybe was initially kind of surprising to me was my patients with rheumatoid arthritis or lupus, some of these autoimmune inflammatory conditions that started this medication because they had maybe coexisting diabetes or because they were obese, and noticed almost immediately that the joint pain started to improve. And you see a wide range of ages. A lot of times with lupus, you see it affecting younger women. And I've had patients that said, I was started on this medication when it first came out, and I was just absolutely shocked at, I tried everything for my lupus and I couldn't get it under control. And then I started this medication and I immediately noticed that my joint pain had improved. And for the first time, I could get on the floor with my kids and play with my kids and actually be able to get back up again. And these are, women in their 20s, 30s, 40s.
Wow.
And then you fast forward a year later where they're consistently taking a maintenance dose and they're doing really well. And then all of a sudden insurance stops paying for Manjaro, for example, because they don't have diabetes. They were just taking it for weight management. And so their insurance doesn't cover it anymore. They can't afford the $1,000 a month to pay for the medication. And they're terrified that they're going to be taken off of this medication because they think the joint pain is going to come right back. And they're afraid that they're going to be debilitated again. They're not going to be able to play with their kids. And so I think having the opportunity to safely use compounded medication in that instance where you actually can afford the medication, you have access to the medication, there aren't shortages anywhere. I think it's very powerful. And I've had people with rheumatoid arthritis that just within 2 to 4 weeks of using the medication, they say, gosh, my knees feel so much better. And that just shows it's not the weight loss. Like, you can't possibly lose enough weight in 2 to 4 weeks to notice the effects of weight loss on your knees, on your arthritis. And so I think it's powerful to see that in patients and to see that these other benefits are going on.
No, it is. And I think I really appreciate you explaining that, because it's more than just the weight loss, that controlling your food noise, and looking at the inflammation properties. And I think that if you are a patient and they're listening to you right now and they have these other issues and things like that they are considering these GLP-1s, what actions should they take to move forward? Like, hey, I want to do this. What do you recommend?
Yeah, I think that's a difficult scenario because the medication is not FDA approved strictly for inflammation. That's and right. It's not something where if you have if you have lupus or you have rheumatoid arthritis or other autoimmune conditions like inflammatory bowel disease, you can't just get a doctor to write you a prescription because it hasn't been studied enough. And we touched on it already about the different types of studies, in vitro studies, in vivo studies, mice versus humans. There's not enough, I think, high-powered studies in humans with those certain types of inflammatory conditions without that coexisting obesity or diabetes, where you can say, yes, let's just start people on this medication strictly for the inflammatory benefits. I think there's a lot more research that needs to be done, and specifically in humans. And so I'm not saying let's just put it in the water supply. I think you still need to be cautious, but I think the whole point is to maybe look at these medications in a different way and not demonize them or demonize the people who are on them, saying that they're just looking for cosmetic improvements,
Right.
because I think they can be so life-changing in a lot of ways.
Right. And I think the podcast, just going back to that podcast, I actually listened to it with you, very fascinating because I think the doctor on the show, there was two different opposing views. Like one was super, super against, which I understand what he was saying. He's saying that we need to fix the issues with school lunches. Have you guys seen school lunches nowadays? Like, I don't remember about you guys, but growing up, you get like a pizza. I remember Pizza Day.
It's like Italian Dunkers.
Yeah,
And
or there's fruit cups. Those fruit cups have more sugar than a damn candy bar. And I used to drink it like, drink it all up. You know what I mean? And so, and it really starts there, like sugar water. You know, like the soft drinks, like, and just
vending machines.
Exactly, it's
Yeah.
all available. All food is available, and in the United States, it's even worse. Like you look at Fanta. I was looking at this the other day. And you look at Fanta in the UK and Fanta in the United States. Fanta in the UK was like actual like almost orange juice with some additives. Fanta in the United States is sugar water and all the additives and the dyes and all that. It did look better in the United States, but guess what? It was artificial. I'm digressing, but that's so important. And I think it's important to show both sides. But what was interesting about the doctor saying that on the podcast was she was saying she was using microdosing of this very specifically. And I think, was she a functional medicine specialist?
Yep. Yeah, she was a naturopath.
Naturopath. There you go. Okay. I don't know the difference between the two. But anyway, and she was microdosing her patients on these certain ailments and just showed a radical change and below the recommended use of what the, like Mounjaro and Ozempic. And I just thought I latched onto that. I was like, that's fascinating.
Well, I think it was interesting what she was saying too, in that a lot of the patients that she was using it for, or she saw lower doses, not necessarily micro doses, but she was doing, I think she was saying maybe like 0.1 milligram dose, where the starting dose for semaglutide is 0.25.
Right,
so
right.
doing even kind of like half of the starting dose.
Exactly.
And doing this in people who are already kind of metabolically healthy, but potentially had other maybe musculoskeletal injuries or some hormonal imbalances, and seeing these really small doses impact them in a positive way. And maybe they were slightly metabolically unhealthy, but not to the degree that people who are obese or who have diabetes or metabolic syndrome would be.
Right.
Because I think we do see in those people that they're maybe even resistant to, not just insulin resistant, or leptin resistant, but they're also resistant to these GLP-1 medications. And there was one study that I read that did say that some of the receptors in obese patients were more resistant to GLP-1. And so for those patients, they might need higher doses. You have to kind of ramp them up to higher doses for them to see the effects. So I think it just shows that everybody's different, and that we should be treating the patient as an individual human instead of the masses.
That's what we believe in. Even though like studies, massive studies, they do help. They're benchmarks, right? But they're not the one size fits all. And that's why a lot of patients turn to functional medicine, is because they tried everything and it doesn't work for them. And when they tell their doctor, sometimes they just feel like they're not being heard. And this isn't no slam against the doctor, but their traditional training may not be applicable to that one individual patient. And so, anyway, all right, Em, give me some takeaways and take a stand. Where are you? So what's the takeaways you want to give the listeners for today?
I mean, I think these are great medications.
So Emily's taking a stand first.
I don't think that they're necessarily for everyone, and I think that they should be used cautiously. but I think they are a wonderful tool that we have in our tool basket, and we're seeing all of these potential benefits. I think they're here to stay. And I think the biggest thing right now is how do we make them affordable and how do we make this sustainable? I think that's really the big question. We can't bankrupt the American healthcare system by supporting the use of these $1,000.
Well, it starts with the damn what's the name? Nordic?
Nodo Nordisk.
Nodo Nordic. Why don't they charge us what they charge in UK?
I don't know.
And they can get pissed off all they want to, but this is why all these other companies are compounding this medication. I just get really concerned about when the FDA takes this drug off the compound list. What the hell are we going to do? That's my biggest takeaway. And that's a scare tactic. We don't really talk about that, because a lot of people are getting this. And I do believe the way that you are supplying it is very, very safe, which we did a whole episode on that. Again, guys, if you haven't seen the episode, please watch the episode. It could be life-saving for you. Don't buy it from your hairdresser. Don't buy it from your neighbor. Don't do that. So anyway, anything else you want to say?
No, I think it's always a hot button issue. I think everybody will have opposing views.
100%.
Sometimes people are so passionately for or against it that it doesn't matter what you say. But I think that there are situations, and I think that they can be life-changing for people. So
I agree.
I guess I don't know if that's really me taking a stand. But
No, you took a stand. You're for these medications, and do it cautiously, and make sure you understand your individual needs and your risk tolerance and profile. I think that's really what I got from today's discussion. So, all right, guys. Well, that's another episode of Seuss and Scrubs. We talk about a little bit of health,
a little bit of wealth,
and a lot of love. Until next time. Bye.
He's on the hustle, she's on the grind. There's no time to kill. For saving lives and new deadlines, and there's some holes to fill. With a little health and a little wealth and a lot of love. That's a life that we live. Seuss and Scrubs.